Good afternoon, dear colleagues. Today we will talk about different efficacy drugs in different population, exploring the varying efficacy of drugs and different doses across different population. I have received many questions concerning on this topic. Why? Because genetic polymorphism now playing a great role in efficacy and in safety of drugs. And pharmacovigilance cover not just questions of adverse reactions, off-label use, medication errors, but an efficacy drugs and all reasons of it. There can be reasons of inefficacy of drugs too. For our new participants, I would like to introduce myself. My name is Galina Cardera. I am qualified person of pharmacovigilance, head of pharmacovigilance department, clinical expert of GVP.Farmak, and do my main activities. I met many situations when medication errors were reasons of adverse reaction and inefficacy of drugs. It's one of reasons. But we will talk today about genetic polymorphism, ethnic variability of this problem with efficacy too. I would like using my opportunity to talk about it in my lecture today, in my webinar today about my YouTube channels, Drug Safety from Galina Cordero, and about my site on Medicine.net. Please subscribe to my on my YouTube channel. It includes actual information in my video lectures, and it's now charge-free. Usability to meet new knowledge. I am now working on book clinical aspect of pharmacovigilance 2, already in stage of preparation, design with my partners electronic books, e-books. It will be electronic books, basic course of pharmacovigilance, and it will be pharmacovigilance quality system, pharmacovigilance quality system with discussion all challenges, mistakes in quality system pharmacovigilance. And please subscribe to my partners too. I have two partners. First partner is Standard Technology and Development, and it will be a webinar concerning on pharmacovigilance quality system. And in November, with my another partner by Science Innova, it will be pharmacovigilance guide for QPPV, with based on my experience. I think it will be interesting for you too. Concerning on program, you can meet on my YouTube channel webinar pharmacovigilance education. I'm working together with academic university and by Science Innova program concerning on medical doctor pharmacist, and it will be useful for pharmaceutical industry too. It will be how to become a specialist from zero in pharmacovigilance field, and it will divide it in 3 levels: basic level, intermediate level, and fluent level, like all schools building. Plus it will be very useful for improving knowledge. Why? Because it will include not just webinars but and workshop. Plus it will include Afterwards, you can buy my electronic books too, and with more practical cases discussion, with scenarios practical, with multi-choice questions, and you can talk with me in LinkedIn. You can send questions in LinkedIn and by my email halina.gmail.com, and we can discuss all your questions in my future webinars too. Today we will talk about understanding drug efficacy, the role of dosing, population variability in drug response, a comprehensive overview, pharmacokinetic and pharmacodynamics, how doses affect different groups, clinical trials evaluating drug efficacy across various demographics, customized treatment, the importance of personalized medicine, and challenges in drug development, addressing efficacy in diverse population. When we're talking about understanding drug efficacy, the role of dosing, we should take into account influence of doses on drug effectiveness. It means optimal dosing for maximum efficacy, and it defines the optimal dosing range and is crucial for maximizing the therapeutic effects of a drug while minimizing potential side effects. Dose response relationship. The dose response relationship illustrates how varying doses can lead to different levels of efficacy, highlighting the importance of precise doses. Impact of overdosing. Underdosing can lead to suboptimal treatment outcomes, while overdosing risks toxicity. Both scenarios underscore the need for careful dosing strategies. Variability in drug response across population. We should take into account genetic difference in drug metabolism. We will talk about it in this lecture. Genetic variation among individuals can significantly affect how drugs are metabolized, influence the dosage requirements and overall efficacy. Age and weight consideration. Age and body weight play critical roles in determining appropriate dosing, as these factors can alter drug absorption and distribution in the body. And health status and comorbidities. Patients' health status, including existing comorbidities, can impact drug efficacy and associate adjustment in dosing regimes to ensure effectiveness. Genetic difference in drug metabolism, it's a topic which now very important in pharmacovigilance. Genetic difference in drug metabolism are primarily due to variations in genes encoding drug metabolized enzymes, transporters and receptors, which influence how individuals absorb and respond to medication. This genetic polymorphism can lead to significant difference in drug efficacy, a required dosing, a risk of adverse effects among individuals and across population. Below are key genetic factors involved in drug metabolism and examples and how they impact clinical practice. Cytochrome P450 enzymes mechanism. Cytochrome P450 family of enzymes, particularly cytochrome P2D6, cytochrome 2C9, cytochrome P2C19, and cytochrome P3A4, is responsible for metabolizing the majority of drugs. Polymorphism in these genes can classify individuals into different metabolizer types: poor, intermediate, extensive, normal, ultra rapid metabolizers. Clinical impact. Cytochrome P2D6 variability affects drugs like codeine, antidepressant, and beta blockers. Poor metabolizer may experience reduced effectiveness, while ultra rapid metabolizers risk toxicity. For instance, codeine is less effective in poor metabolizers and potentially toxic in ultra-rapid metabolizers due to rapid conversion to morphine. Cytochrome P2C19 impacts clopidogrel, proton pump inhibitors, and certain antidepressants. Poor metabolizer may have reduced efficacy, with clopidogrel requiring alternative antiplatelet therapy. Cytochrome 2C9 affect warfarin metabolism with poor metabolizer at increased risk of bleedings. Genetic testing helps determine lower starting doses to avoid adverse events. UDP glucuronidyltransferases, UGTS mechanism, UDP glucuronidyltransferases enzymes, especially UGT1A1, are involved in phase 2 metabolism, facilitate drug excretion by attaching glucuronic acid to drugs. Clinical impact UGT1A1 variants impact metabolism of irinotecan, a chemotherapy drug. Reduced UGT1A1 activity can lead to toxic levels, causing severe side effects. Patients with these variants may need reduced doses of irinotecan. Thiopurine methyltransferase mechanism metabolizes thiopurine drugs such as azathioprine and mercaptopurine, commonly used in cancer and autoimmune disorders. Clinical impact: individuals with slow thiopurine methyltransferase activity are at risk of severe bone marrow suppression when treated with standard doses of thiopurines. Genetic testing can identify thiopurine methyltransferase deficient patients, allowing for dose reduction to prevent toxicity. Vitamin K epoxide reductase complex mechanism is crucial in the vitamin K cycle and influences warfarin metabolism. Clinical impact: variants of vitamin K epoxide reductase complex 1 increase sensitivity to warfarin, necessitated lower doses to prevent bleeding. Combined and tested of vitamin K epoxide reductase complex 1 and cytochrome 2C9 genes is often used to get warfarin dosing. An acetyltransferase mechanism is responsible for metabolizing drugs like isoniazid used in tuberculosis and certain antihypertensives. Clinical impact: individual can be classified as slow effect acetylators. Slow acetylators are at higher risk of toxicity with drugs like isoniazid, potentially causes side effects like neuropathy. Dose adjustment based on NAT2 status can reduce toxicity. Organic anion transporter polypeptiditis and SLCO1B1 mechanism encodes and transporter that affects hepatic uptake of drugs, especially statins. Clinical impact: variants in organic anion transporter polypeptidase and SLCO1B1 can increase statin levels, raising the risk of statin-induced myopathy. Lower statin doses or alternative statins are often recommended for individuals with these variants. Glucose 6-phosphate dehydrogenase mechanism. Glucose 6-phosphate dehydrogenase protects red blood cells from oxidative stress. Deficiency in glucose 6-phosphate dehydrogenase can lead to hemolytic anemia when exposed to certain drugs. Clinical impact: glucose 6-phosphate dehydrogenase patients are at risk when treated with drugs like primaquine and certain antibiotics. Avoiding these drugs or using lower doses can prevent hemolysis in glucose 6 phosphate dehydrogenase deficient individuals. P-glycoprotein ABCB1 mechanism encoded by ABCB1 gene P-glycoprotein acts as a transporter that pumps drugs out of cells, influencing drug absorption and elimination. Clinical impacts. Variants in ABCB1 can affect the bioavailability of drugs like digoxin, anti-cancer agents, and HIV medication. Adjusting doses or monitoring levels can be helpful for patients with ABCB1 variants. Summary. Genetic difference in drug metabolism are critical for understanding individual responses to medication. Pharmacogenetic testing, where available, enables personalized dosing based on genetic makeup, improving drug efficacy and reducing adverse effects. This approach is particularly beneficial for drugs with narrow therapeutic window, higher toxicity risk, ensuring safer and more effective treatments tailored to individual metabolic profiles. Environmental lifestyles factors, diet, lifestyle, and environment exposures play a substantial role in drug metabolism by modulated enzyme activity in drug disposition. Examples: high fiber diets common in some populations can affect the absorption of drugs such as digoxin. Smoking alter metabolism by inducing cytochrome 1A2 influences the effect of drugs like theophylline. Social-cultural factors and health beliefs. Beliefs about medication adherence patterns, access to healthcare can affect drug outcomes across population. Examples: adherence patterns. In some communities, traditional medicine practices may influence adherence to prescribed therapies. Healthcare access. Economic and cultural barriers in accessing healthcare impact drug adherence and outcomes in certain populations. Population-specific variability in drug response. East Asian populations, cytochrome 2C19 polymorphism, higher prevalence impacts this metabolism of clopidogrel, and proton pump inhibitors often require alternative drugs for effective treatment. Warfarin sensitivity, Vicky or C1 variants necessitate lower doses to prevent bleeding risks. Statins, CLC, SLCO1B1 polymorphism increase the risk of myopathy, often needed lower starting doses. African population, cytochrome P385 variants, higher prevalence impacts the metabolism of tacrolimus, often require dose adjustments for immunosuppressive therapy. Antihypertensive response, reducing transport response to ACE inhibitors, angiotensin. We know it that in African population level of renin is lower. It's why reduced response to IC inhibitors and beta blockers with calcium channel blockers and diuretics, typically offering better blood pressure control. And glucose 6 insufficiency, G6PD deficiency, higher risk of hemolysis with drugs like primaquine and certain antibiotics, requiring careful drug selection. European population, cytochrome P2D6 and cytochrome 2CD polymorphism impact the metabolism of antidepressants, antipsychotics, and non-steroid anti-inflammation drug and CADs often require personalized doses. Warfarin sensitivity variants of VKOR C1 and cytochrome 2C9 lead to increased sensitivity, needed lower doses to avoid bleeding. and TPMT deficiency, common in Europeans, affecting theoporine metabolism associated lower doses to prevent myelosuppression. Middle Eastern population, cytochrome P2D6 and cytochrome P2C19 polymorphism, influence and response to antidepressant, antiplatelet, and opioids, often require dose adjustment or alternative medication. CLC1 B1 variants, risk of statin-induced myopathy, may necessitate lower doses of use of alternative statins. Latina and Mexican population with KORC1 and cytochrome 2C9 variants impact warfarin doses similar to East Asian population with lower doses needed to prevent bleeding. Cytochrome P2C19 polymorphism common among Latinos affecting clopidogrel metabolism requiring alternative antiplatelet agents for poor metabolizers. Antihypertensive response similar to African population with diuretic and calcium channel blockers, often more effective than ICA inhibitors. Age and weight consideration. Age consideration, pediatric population, a psychological difference. Children have a mature organ system, especially liver and kidneys, that influence drug absorption, metabolism, and excretion. The maturity can lead to slower drug clearance or altered drug distribution. Dose adjusting weight-based dosing, pediatric dosing are often calculated per kilogram and body weight milligram per kilogram. That's why we should understand that the different pharmacokinetic, pharmacodynamic, and children is not young older to account for difference in body size and drug clearance. Age-specific formulation, liquid formulation, smaller tablet doses are used to improve safety and adherence. Avoidance of certain drugs. Drugs like aspirin and tetracyclines are avoided in young children due to risk of Ray's syndrome and effects of bone and teeth development, respectively. Neonates and infants. Physiological immaturity. Neonates, newborn infants have immature enzyme system, blood-brain barriers, and slower gastric emptying, impacted drug absorption and metabolism. Dosing adjustment, special formulation, neonatal dosing often requires specialized formulation or intravenous preparation to ensure a precise dosing. Avoiding certain drugs. Drugs like sulfonamides are avoided in neonates due to the risk of kernicterus, bilirubin-inducing brain damage, as their blood-brain barrier is not fully developed. Geriatric population. Physiological changes. Older adults experience decreased renal and hepatic function, changes in body composition, higher fat to lean body mass ratio, and altered receptor sensitivity, which can affect drug metabolism and response. Dosing adjustment. Lower starting doses, start low and go slow, is a common principle in geriatric dosing to reduce the risk of side effects, and older adults are more sensitive to drugs and may have slower clearance rates. Monitoring for polypharmacy. Older adults often take multiple medication, increasing the risk of drug-drug interaction and adverse effects. Regular medication reviews are crucial to avoid inappropriate prescribing. Avoiding higher risk drugs. Certain drugs and benzodiazepines, NSAIDs, are used with caution or avoided due to an increased risk of falls, bleeding, and other adverse events. Weight consideration. Underweight and low body mass, impact of drug distribution, Underweight patients have lower fat stores and lean body mass, which affects distribution of lipophilic fat-soluble drugs and water-soluble drugs. Dosing adjustment. Lower dose of lipophilic drugs like diazepam may be dosed lower to prevent accumulation and toxicity, as underweight individuals may have less fat tissue to store these drugs. Careful monitoring. Drug levels may need to be monitored more frequently, particularly with drugs that have narrow therapeutic windows. Overdose, overweight, and obese population. Impact of drug distribution. Obese individuals have a higher fat mass, which affects the distribution of lipophilic drugs, often leading to longer drug half-lives and slower clearance. Dosing adjustment. Adjusted dosage for lipophilic drugs, drugs like benzodiazepines and certain anesthetics may require dose adjustment based on adjusted body weight or lean body weight rather the total body weight to avoid toxicity. Consideration for water-soluble drugs. For water-soluble drugs, intermittent dosing based on lean body weight is often appropriate as they distribute mainly in the extracellular fluid. Weight-based dosing. Many drugs, particularly in pediatric and critical care setting, are dosed per kilogram of body weight. This method accounts for individual variation in drug clearance or body composition, helping to ensure a safe and effective dosing. Clinical implication of age and weight-based dosing. Pediatric consideration. Weight-based dosing is standard in pediatric to achieve precise dosing, given children's varied metabolic rates and development stage. Geriatric consideration. Lower starting doses and regular monitoring are key to minimize adverse effects and avoiding drug accumulation due to age-related declines in organ function. Obesity and overweight consideration. For drugs with different distribution patterns, dosing based to lean or adjusting body weight was this very important rather than total body weight helps tailor treatment to an individual's unique physiology and reduces overdose risk. Summary. Age and weight significantly affect drugs response, necessitated dose adjustment tailored to individual characteristics. Weight-based doses, careful monitoring, and considering physiological changes due to age help optimize safety and efficacy across diverse patient population, particularly in pediatrics, geriatrics, and patients with extreme body weight. Impact of health status and comorbidities on drug therapy. Liver disease mechanisms. The liver is responsible for the metabolism of most drugs. Conditions such as cirrhosis, hepatitis, or liver failure impair liver function, reducing drug clearance and increasing the risk of toxicity. Dose adjustment. Reduced doses for drugs primarily metabolized by the liver, opioids, benzodiazepines, statins, lower doses or extended doses intervals are often necessary. Monitoring. Regular liver functional tests, Efficacy, and therapeutic drugs monitoring can help adjust doses to avoid hepatotoxicity and maintain effectiveness. Avoiding certain drugs. Hepatotoxic drugs like acetaminophen in higher doses and some antifungals are used cautiously or avoided in patients with significant liver disease. Kidney disease. Mechanism. The kidneys are essential for drugs excretion. Chronic kidney disease or acute renal failure can lead into drug accumulation, increasing the risk of toxicity for drugs excreted through the kidneys. Dose adjustments, low doses and adjustment intervals. Drugs like antibiotics, aminoglycosides, vancomycin, antidiabetics, metformin, and antihypertensives hypertensives required lower doses or extended intervals in renal impairment. Monitoring. Regular monitoring of kidney function, GFR, creatinine clearance, and therapeutic drugs levels help ensure safe dosing. Avoiding nephrotoxic drugs, medications such as NSAIDs, certain antibiotic, aminoglycosides, and contrast agents should be used with caution and as they can worsen kidney function. Cardiovascular disease mechanism, heart condition like heart failure, arrhythmias, and hypertension impact drug distribution, metabolism, and therapeutic effects. Reducing cardiac output in heart failure affects drug delivery to tissue and organs. Dose adjustment, lower or adjustment doses in heart failure, like beta blockers and diuretics may require gradual dose titration and avoid worsening symptoms. Additionally, drugs metabolized by the liver may have reduced clearance due to poor hepatic perfusion. Monitoring. Regular monitoring of electrolytes, blood pressure, and heart rate is essential, particularly when using diuretic, antihypertensive, or antiarrhythmics. Avoiding certain drugs. Some drugs, like NSAIDs, can worsen heart failure by causing fluid retention. Others, like certain antiarrhythmics, can exacerbate antiarrhythmias. Diabetes. Mechanism. Diabetes affects drug absorption, metabolism, and excretion, particularly in the presence of complications like nephropathy or neuropathy. Diabetic patients are also at higher risk for infection, which may alter drug needs. Dose adjustment, hyperglycemia risk. Diabetic patients may require adjustment doses of insulin or oral antidiabetics, especially when prescribed with other drugs that increase hyperglycemia risk, beta blockers, sulfonylureas. Kidney monitoring. Diabetes is leading cause of CKD, so monitoring kidney function is critical when prescribing nephrotoxic or renal excreted drugs. Avoiding certain drugs, corticosteroids, and some antipsychotics can raise blood sugar level, so their use is limited or carefully monitored in diabetic patients. Respiratory disease like COPD or asthma, we are talking of impact of health status and comorbidities on drug therapy. Mechanism. Respiratory conditions impact drug metabolism and efficacy, especially for inhaled therapies. Certain drugs can exacerbate respiratory symptoms or interact with respiratory medication. Dose adjustment. Inhaled medication. Dose adjustment may be necessary for inhaled corticosteroids or bronchodilators to avoid systemic effects, particularly in severe COPD. Avoiding respiratory depressants. Drugs like opioids, sedatives, and beta blockers, non-selective, should be used cautiously and they can worsen respiratory function and exacerbate symptoms. Obesity. Mechanism. Obesity affects the volume of distribution for lipophilic and hipophilic drugs, often required dose adjustment. Additionally, metabolic changes in obesity can alter drug metabolism. Dose adjustment. Adjusted body weight dosing for certain drugs, dosing based on adjusted body weight rather than total body weight is presented to avoid toxicity. Drugs like aminoglycosides may require adjusted body weight dosing. Monitoring for complication. Obese individuals often have comorbidities like diabetes and cardiovascular disease, requiring careful monitoring for potential interaction and adverse effects. Cancer mechanism. Cancer patients often have compromised organ function, liver or kidney, due to disease or chemotherapy impacted drug metabolism. Cancer can also increase susceptibility to infection, requiring adjustment in antimicrobial therapy. Dose adjustments, lower or titrated doses. Certain chemotherapeutic agents, immunosuppressants or supportive drugs like analgesics require lower doses or adjusted schedules in the presence of compromised liver or kidney function. Avoiding immunosuppressive agents. Patients receiving chemotherapy may require careful selection of immunosuppressive or potential toxic drugs to avoid exacerbating immunosuppression. Common higher risk drug combination polypharmacy via included it because it can be source of adverse reaction and influence on efficacy too. Anticoagulants and steroids and CIDs risk increased bleeding risk mechanism. Both anticoagulants, warfarin, apixaban, and NSAIDs like ibuprofen, naproxen, increasing the risk of bleeding, particularly in the gastrointestinal tract. Management. Avoid concurrent use if possible. If necessary, use the lowest effective NSAIDs dose for the shortest duration and consider gastroprotective agents. Opioids or benzodiazepams. Diazepams. Opioids and benzodiazepams risk respiratory depression and sedation. Mechanism. Both drugs classes depress the central nervous system, CNS, compounding the risk of respiratory failure and profound sedation. Management. Avoid concurrent use when possible. For patients who need both, consider alternative therapies, close monitoring, and lower doses of each drug. Educate patients about the signs of respiratory depression. ACE inhibitors, diuretics, and CDS reply FAMI, risk acute kidney injury, mechanism ACE inhibitors or RBC, reduce kidney perfusion, diuretic decrease blood volume, and CDS reduce renal blood flow. Together, they significantly reduce kidney function. Management. Avoid this combination, especially in patients with pre-existing kidney disease. Monitor kidney function and educate patients or things of kidney issues like reducing urine output. ACE inhibitors, diuretic enzymes, we talked about it. Now we talk about antidepressants, CCRAC, like sertraline, TCH, and antiplatelet or anticoagulants. Risk. Increase in bleeding risk. CCRIs and TCAs can inhibit platelet function, compounding the bleeding risk when using with anticoagulants or antiplatelet. Management. If concurrent use is necessary, monitor for signs of bleeding and consider gastroprotective agents to reduce the risk of GI bleeding, gastrointestinal bleeding. Dioxin and diuretic, especially loop diuretics, risk dioxin toxicity mechanism. Diuretic can cause electrolyte imbalances, low potassium and magnesium, which can increase the risk of dioxin toxicity, leading to arrhythmias. Management. Monitor electrolyte levels and adjust doses as needed. Educate patients on signs of dioxin toxicity such as nausea, dizziness, irregular heartbeats, corticosteroids and antihyperglycemics risk worsening hyperglycemia, leukemia. Mechanism. Corticosteroids increase blood glucose levels, potentially interfering with glycemic controls in diabetic patients. Management. Closely monitor blood glucose levels in patients on both medication and adjust antihyperglycemic dose as needed. Consider alternative therapies if blood glucose control becomes challenging. MAO inhibitors and sympathomimetics drugs risk hypertensive crisis. Mechanism: monoamine oxidase inhibitors, phenylzine, prevent the breakdown of catecholamines, and sympathomimetic drugs like pseudoephedrine increase catecholamine levels, leading to dangerous hypertension. Management: avoid combining these drugs. Educate patients on avoided over-the-counter sympathomimetics and certain foods that can also elevate blood pressure. Statins and cytochrome P3A4 inhibitors, macrolides, azole antifungals, increased risk of statin-induced myopathy or rhabdomyolysis. Mechanism: cytochrome P3A4 inhibitors can increase blood levels of statin metabolized by cytochrome P3A4, such as simvastatin and atorvastatin, elevated the risk of muscle toxicity. Management: use lower doses of statins or consider statins less reliant or cytochrome P3A4 metabolism, such as pravastatin or rosuvastatin. Avoid macrolide antibiotics if possible. Antipsychotic and QT prolonging drugs increasing risk of QT prolongation and potentially fatal arrhythmias. Tarsal points. Mechanism: many antipsychotics and other drugs, certain antibiotics, antiarrhythmics prolong the QT intervals, compounding the risk of dangerous arrhythmias when combined. Avoid combining QT prolonging drugs when possible or monitor ECG closely if necessary. Use alternative medications that do not prolong the QT interval. Phenytoin and warfarin risk altered anticoagulant effect and potential toxicity. Mechanism: phenytoin can both induce and inhibit warfarin metabolism, leading to fluctuation and warfarin levels and difficulty maintains and stable INRE. Management: monitor INRE levels closely and adjust warfarin dose as needed. Educate patient on things of both bleeding and coating. Lithium and diuretic, especially thiazides, risk lithium toxicity. Mechanism: thiazide diuretic can reduce renal clearance of lithium, leading to increased lithium levels and toxicity. Management: avoid this combination if possible. If necessary, closely monitor lithium levels and renal function, adjusting the lithium dose as needed. Educate patients on things of toxicity, such as tremor and confusion. Calcium channel blockers, non-DHP, and beta blockers increased risk of bradycardia and heart block. Mechanism: both non-dihydropyridine calcium channel blockers like verapamil, diltiazem, and beta blockers reduce heart rate and contractility, which can lead to bradycardia and heart block. Management: avoid combining these drugs unless necessary and monitor heart rate closely if they must be used together. Clinical implications of dosing strategies include tailored dosing for individual patients. Personalized medicine emphasizes the importance of tailored dosing strategies based on individual patient characteristics for optimal outcomes. Monitoring and adjusting doses, regular monitoring of patient responses allow healthcare providers to adjust dosing strategies as needed to maintain efficacy and safety. Guidelines for safety dosing practices. Establishing clear guidelines for dosing practices can help minimize the risk of adverse effects and improve overall drug efficacy. across population. Clinical implication of dosing strategies. Dosing strategies are crucial in clinical practice. They are directly influence the efficacy, safety, and overall outcomes from drug therapy. The goal of any dosing strategy is to achieve therapeutic drug concentrations that provide maximum benefit with minimal risk of toxicity. Factors such as age, weight, organ function, genetics, and comorbidities affect the optimal dosing for individual patient. Fixed doses, individualized dosing. Fixed doses. This approach uses a standard dose for all patients, often based on clinical trials that demonstrate efficacy at a specific dose range. Fixed dosing is commonly for drugs with wide therapeutic windows and predictable pharmacokinetics across population. Implication. While convenient and is easy to implement, fixed doses may not be suitable for drugs with narrow therapeutic indices or for indices for patients with unique physiological characteristics such as those with liver or kidney impairment. Individualized doses are tailored based on individual patient factors like age, weight, organ function, and genetic polymorphism. Implication. Individualized doses improve efficacy and reduce the risk of adverse effects, particularly for drugs with narrow therapeutic windows like warfarin, digoxin. However, it may require more frequent monitoring and adjustment. Weight-based doses. Strategy. Weight-based dosing is commonly in pediatric oncology care, where doses are calculated per kilogram of body weight. This approach helps account for difference in body size, which can impact drug distribution and metabolism. Implication. Weight-based dosing alone for more precise dosing, especially in pediatrics and with drugs that have weight-dependent pharmacokinetics. However, it may be less appropriate for extremely overweight or underweight patients where alternative dosing adjustment, adjusted body weight, might be more effective. Age-based doses strategy. Age-based doses taking into account age-related physiological changes that may affect drug metabolism, such as slower clearance and altered volume of distribution in older adults. Implication. In pediatric and geriatric population, age-based dosing helps avoid toxicity. For example, lower starting doses are often used for elderly patients due to age-related declines in liver and kidney function. In pediatrics, dosing formulas that consider development stages ensure safe and more effective therapy. Renal and hepatic dosing adjustment strategy. Doses are adjusted based on renal or hepatic function, commonly measured by biomarkers like creatinine clearance, SFR, or liver enzyme levels. Implications. These adjustments are critical for drugs primarily eliminated by the kidneys or metabolized by the liver. Failure to adjust doses in patients with renal or hepatic impairments can lead to drug accumulation and toxicity, particularly with drugs like aminoglycosides, renal doses, and opioids, hepatic doses. Loading dose and maintenance dose. Loading dose. A loading dose is high initial dose used to rapidly achieve therapeutic levels, especially for drugs with long half-lives or those needed urgently, such as antibiotics. Maintenance dose. Maintenance doses are smaller doses given at regular intervals to keep the drug within the therapeutic range. Implication. Loading doses are particularly useful in acute setting, allow with repeat onset of drug action, as with antiarrhythmics or anticoagulants. However, careful calculation and monitoring are necessary to avoid reaching toxic levels, especially when transitioning from loading to maintenance dosing. Therapeutic drugs monitoring strategy. Therapeutic drug monitoring involves measuring drug concentration in the blood to guide dosing for drugs with narrow therapeutic windows or highly variable pharmacokinetics such as lithium, phenytoin, and vancomycin. Implication: therapeutic drug monitoring enables personalized dosing based on actual drug levels in the patient, reducing the risk of toxicity or subtherapeutic effect. However, therapeutic drug monitoring requires regular blood sampling and can be costly and research intensive, often reserved for specific higher risk drugs. Pharmacogenetic guided dosage strategy: pharmacogenetic testing identifies genetic polymorphism that affect drugs metabolism, guiding dose adjustments for drugs metabolized by polymorphic enzymes as cytochrome P2D6 for antidepressant or cytochrome P2C9 for warfarin. Implication: personalized dosing based on genetic testing improves efficacy and minimizes adverse effects, particularly for drugs with genetic variability in the metabolism. Pharmacogenetic guided dosing is emerging practice. They may not yet be available for all medication or patients. Intermittent continuous doses. Intermittent doses, administering drugs at set intervals twice daily, is common in outpatient setting. Continuous dosing in critical care: some drugs are given continuously to maintain stable blood concentration, especially for drugs with short half-lives. Implication: continuous doses can reduce fluctuation and maintain stable levels in the therapeutic range, which is ideal for certain antibiotics and anesthetics in intensive care. However, continuous doses require uh, for administration and more frequent monitoring. Fixed or flexible dosing in pain management. Fixed doses: regular scheduling dosing without waiting to pain intensify, around the clock dosing for chronic pain. Flexible dosing: adjusting doses based on pain intensity or breakthroughs pain episodes. Implication: fixed doses is more effective for managing chronic pain, reducing pain intensity fluctuation. Flexible dosing is helpful for acute pain or breakthrough pain, allowing patients to adjust their dose as needed. Dose escalation strategy: gradually increasing the dose of drug until the desired effect is achieved or until side effects limit further increases, commonly used in chemotherapy as psychotropic medication. Implication: dose escalation can minimize adverse effects by gradually allowing the body to adapt to the drugs. However, it requires carefully monitoring to ensure the dose remains within the therapeutic window and avoid toxicity. Monitoring and adjusting doses. Therapeutic drug monitoring purpose. Therapeutic drug monitoring involves measuring drug concentration in the blood to ensure they stay within therapeutic range, particularly for drugs with narrow therapeutic windows, lithium, digoxin, vancomycin. When to use drugs with narrow therapeutic indices or higher toxicity risk, drugs with significant pharmacokinetics variability, anticonvulsant, situation where patient factors, organ dysfunction alter drug clearance. Process: initial measurements. After reaching steady state, typically 3-5 half-lives, a blood sample is taken to assess drug levels. Ongoing monitoring: levels are regularly checked, especially if there is a change in dosing, new drug interaction, or alteration in health status. Implication: therapeutic drug monitoring allowing dose adjustment based on actual drugs levels, reducing risk of underdosing or toxicity. Renal function monitoring purpose: many drugs are excreted through the kidneys, so changes in renal function can lead to drug accumulation and toxicity. When to adjust: reducing kidney function lower doses or longer dosing intervals are required for drugs primarily cleared renally, aminoglycosides, metformin. Monitoring tools, eGFR and creatinine clearance are routinely measured to assess renal function. Regular monitoring, particularly important in patients with chronic kidney disease, of those at higher risk of renal impairment, older adults. Implication: adjusting doses based on renal function prevent accumulation and toxicity, particularly for drugs with narrow therapeutic windows. Adjusting for age and body weight. Purpose: age-related changes in organ function at different body weights impact drug distribution, metabolism, and clearance. When to adjust: pediatrics, children often require weight-based doses to account for their different metabolic rates and body composition. Elderly, lower starting doses, a gradual titration may be necessary due to reducing liver and kidney function. Obesity, adjusted body weight dosing may be appropriate for some drugs and avoid toxicity. Implication: dosing based on age and weight minimizes toxicity risk and ensures therapeutic efficacy across age groups and body types. Monitoring and managing adverse effects. Purpose: regular monitoring for signs symptoms of drug-related adverse effects allow for timely intervention. When to adjust: adverse effects: if patient experience side effects, dizziness, nausea, liver enzymes elevation, a dose reduction of drug change may be necessary. Signs of toxicity: for example, if the vaccine toxicity symptoms, nausea, virtual change, and appear, the dose should be reevaluated immediately. Tools for monitoring: patient reports and clinical assessment. Patients should be encouraged to report new symptoms, and regular follow-up should assess for common adverse effects. Routine laboratory tests for drugs affecting organs, liver, kidneys. Regular lab tests help coach early signs for toxicity. Implication: early recognition and management of adverse effects improve patient safety and comfort, maintains adherence to treatment. Assessing and adjusting for therapeutic response. Purpose: ensuring the drug achieves and desired therapeutic outcomes without causing harm. When to adjust: suboptimal response: if treatment goals are not met, dose adjustment or alternative therapies may be required. Changing the disease state, for instance, worsening heart failure may necessitate adjusted diuretic or ACE inhibitors. Monitoring tool, clinical assessment, regular assessment of symptoms and objective measures, blood pressure, hemolyzed hemoglobin, HbA1c help gauge therapeutic effectiveness. Biomarkers for conditions like diabetes or hyperlipidemia, monitoring biomarkers, blood glucose, LDL cholesterol provides feedback on treatment effectiveness. Implication: regular assessment of therapeutic response ensures that the patient treatment remains effective and adjusted as needed over time. Regular follow-up and patient education. Purpose: engaging patients, their care improves adherence, recognizes early signs of adverse effects, and enables prompt dose adjustments. When to adjust: patient-reported issues, follow-up visit provide an opportunity for patient to discuss difficult or side effects, prompting possible adjusting. Routine check-ins, regular follow-ups are crucial for chronic disease management to ensure ongoing efficacy and safety. And tools, patient education, educated patient about their medication, potential side effects, and importance of adherence promotes self-monitoring and timely reporting. Adherence monitoring, tools like pill counter, reminder, or mobile apps can improve adherence and help identify missed doses. Implication: frequent follow-ups and patient education encourage adherence and timely dose adjustment, leading to improved clinical outcomes. Guidelines for safety dosing practice. Safety dosing practice are essential to ensure drug efficacy, prevent toxicity, and improve patient outcomes. These guidelines encompass principles for initial dosing, dose adjustment, and monitoring, particularly in patients with complex health profiles or those required higher risk medication. Following this guidance can reduce medication errors, adverse effects, and improve therapeutic results. First of all, it assess patient-specific factors before initiating therapy. Consider age, weight, and body surface area. For pediatric and geriatric patients, adjust doses based on weight or body surface area to ensure safety and efficacy. Evaluate organ function. Assess liver and kidney function, as these organs are initial and vital for drug metabolism and excretion. Dosing adjustment may be required for drugs cleared by these organs. Review comorbidities, identifying any chronic condition, heart failure, diabetes that may affect drug pharmacokinetics or pharmacodynamics. Screen for genetic factors. For certain high-risk drugs, consider a pharmacogenetic tested cytochrome P2C19 for clopidogrel or cytochrome P2D6 for opioids to guide dose selection and avoid adverse reaction. Use evidence-based dosing recommendation. Follow clinical guidelines. Adhere to established dosing guidelines for specific conditions. Hypertension, diabetes, from reputed organization, World Health Organization, Food Drug Administration, NICE. Reference package inserts and drug monographs. Consult the drug's prescribing information for dose recommendation, warning, and any population-specific information, dose adjustment for renal or hepatic impairment. Employ established dosing tools. Utilize dosing calculator or mobile apps designed for healthcare professionals to ensure accurate dose calculation, particularly in pediatrics and critical care. Start low, go slow, principle for high-risk patients. Initial doses is vulnerable population. Start with lower effective dose, particularly in older adults, patients with multiple comorbidities, and those with organ dysfunction. Gradual dose escalation. Titrate dose gradually, monitoring for therapeutic response and side effects, especially for medication with narrow therapeutic windows, opioids, and antidepressants. Frequent monitoring. Monitor closely after dose change to detect adverse effect early and just as needed. Engage in therapeutic drug monitoring for narrow therapeutic index drugs. Regular blood level checks for drugs like lithium, warfarin, vancomycin, measure blood concentration periodically to stay within therapeutic range. Adjust dose based on levels. If levels are too high or low, adjust the dose accordingly. Recheck level after a few days. Consider drug interaction. Be aware of any new drugs added to the regime as it may alter drug levels. For example, cytochrome 450 enzyme inhibitors inducer and adjust doses if necessary. Account for renal and hepatic function in dose selection. Renal function. Calculate creatinine clearance or estimate glomerular filtration to get dose adjustment for renal excreted drugs, antibiotics, metformin. For drugs required renal adjustment, consider extended dose intervals or reducing doses. Hepatic function. Review liver function, ALT, bilirubin before initiated drugs metabolized by the liver. Dose reduction or alternative medication may be required for those with a liver impairment. Recognize high-risk drug combination and avoid polypharmacy when possible. Assess for drug-drug interaction. Use drug interaction checkers or consult with pharmacists for patients who multiply medication to avoid high-risk combination. anticoagulants with NSAIDs, opioids with benzodiazepines, and others. Avoid unnecessary medication. They prescribe non-essential drugs to reduce the burden of polypharmacy and lower the risk of adverse interaction. Monitor for interaction effects. Educate patients on the symptoms of interaction, excessive bleeding, drowsiness, and adjust doses if interactions is unavailable. Adjust body weight and obesity. Calculate appropriate dose for weight. For drugs with specific doses based on body weight, adjust using actual body weight, ideal body weight, or adjusted body weight as appropriate. For example, aminoglycosides are often dosed based on adjusted body weight in obese patients to avoid toxicity. Consider volume of distribution. For lipophilic drugs, dosing may need to consider the increase in fat storage in obese patients, while hydrophilic drugs may require adjustment based on lean body mass. Ensure patient adherence through clear instruction and education. Provide written and verbal instruction. Explain dose schedules, especially for complex regimes on medication taken at different times. Written materials, pill boxes, and reminders can support adherence. Educate on adverse effects. Inform patients about potential side effects and what to do if they experience them. Encourage them to report new unusual symptoms promptly. Simplify dose regimes. When possible, simplify the regime to once daily or twice daily dosing to improve adherence and reduce the likelihood of missed doses. Regularly review and adjust doses based on patient progress. Follow-up appointments. Schedule regular follow-ups to monitor therapeutics effects, side effects, or any change in health status that may necessitate dose adjustment. Check for signs or drug accumulation. For drugs with a risk cumulative toxicity, digoxin, methotrexate, review patient symptoms and laboratory markers regularly to adjust dose proactively. Adjust based on clinical response. If therapeutic goals are not being met, consider increasing dose, switching drugs, or adding adjust therapy. Document dosing changes and rationally thoroughly. Thoroughly. Recording all dosing decisions. Document dosing changes, the reasoning behind adjustment, and any patient instruction in the medical record. Communicate with healthcare team. Ensure that all team members, including pharmacy, nurse, and specialists, are aware of dosing changes, especially in complex high-risk cases. Review regularly. Periodically review the dosing regime to ensure that it remains appropriate to the patient condition on concurrent treatment is changed. Population variability in drug response, a comprehensive overview. The role of genetic variation. Genetic variation among individuals can significantly influence how drugs are metabolized, leading to varying responses in efficacy and safety. Implication for personalized medicine. Pharmacogenomics allow for tailoring drug therapies based on individual genetic makeup, improving treatment outcomes and minimize adverse effects. Case studies demonstrated variability. Numerous case studies highlighting how specific genetic markers can predict drug response, showcasing the importance of genetic testing in clinical settings. The role of genetic variation. Genetic variation plays a central role in influencing individual response for medication. Variations in specific genes affect how drugs are metabolized, transported, and interact with that target within the body, making pharmacogenomic understanding and applying genetic different drug response a cornerstone of personalized medicine. Recognizes this genetic variation enables healthcare providers to tailor therapy to each patient, optimize the treatment outcomes, and minimize adverse effects. Key types of genetic variation and their roles. Single nucleotide polymorphism definition. Single nucleotide polymorphism are the most common type of genetic variation involving single base change in the DNA sequence. Impacts of single nucleotide polymorphism can alter the structure and function of proteins, particularly enzymes involved in drug metabolism, such as cytochrome P450 enzymes, for example, cytochrome P2C19 polymorphism and single nucleotide polymorphism in the cytochrome P2C19 gene can result in poor metabolism of drugs like clopidogrel, affecting drug efficacy. Patients with this polymorphism can require alternative medication for effective therapy. Cytochrome P26 polymorphism and single nucleotide polymorphism. Single nucleotide polymorphism in cytochrome P2D6 affects the metabolism of drugs like codeine and antidepressant, categorized individuals as poor, intermediate, extensive, or ultra-rapid metabolizer. Gene deletion and duplication. Definition. Gene deletion result is the absence of gene while duplication leads to additional copies affecting enzyme activity. Impact. This variation can lead to either absent or increased enzyme activity. Cytochrome P2D6 gene duplication patient with multiplied copies of the cytochrome P2D6 gene are ultra-rapid metabolizer, which can lead to rapid drug clearance and reduces therapeutic effects for certain drugs, like some antidepressants and opioids. Conversely, gene deletion can lead to poor metabolism and increased risk of toxicity. UGT1A1 variation, gene duplication or deletion of UGT1A1 can alter the metabolism of drugs like irinotecan. This variation potentially increases the risk of several side effects, such as neutropenia. Insertion of deletion in DELs. Definition. Insertion or deletion of small DNA segments can affect gene expression or protein function. Impact. Indels can disrupt the normal function of drug metabolized enzymes, transporters, or receptors. TPM variants, gene indels, infect thiopurine metabolism, impacting drugs like azathioprine. Patients with TPMT deficiency metabolize thiopurine more slowly, increasing the risk of toxicity. Lower doses are required for safe therapy. AC gene deletion polymorphisms, variation with AC gene involving insertion or deletion, can influence blood pressure responses. Blood pressure response of AC inhibitors require dose adjustment for optimal control in hypertensive patients. Copy number variation, CNVC. Definition. CNVC refers to larger DNA segments that are duplicated or deleted, leading to multiply or absent copies of gene. Impact. CNVs affect enzyme quantify, thereby influence drug metabolism and response. Cytochrome P2D6 and copy number variation can increase or decrease cytochrome P2D6 enzyme activity, significantly affecting drug metabolism, as seen in patients who are poor or ultra-rapid metabolizer. Gene variants in drug transporter. Definition. Variation in transporter gene impact how drugs are absorbed, distributed, and eliminated from the body. Impact. Transporter gene variants affect drug efficacy and toxicity. CLC1B1 variants, the gene encodes OATP1B1 transporter, affects statin uptake in the liver. Variants of CLCO1B1 can lead to statin accumulation in blood, increasing the risk of myopathy. Patients with these variants may require lower doses or alternative statins. ABCB1 variants, this gene encodes peglycoprotein and transporters the pump drugs out of cells. Variants can affect drug distribution, impacting drugs like digoxin, which requires careful monitoring of therapeutic and toxic levels. Gene variants and drug targets. Pharmacodynamic. Definition. Variation in gene encoding drug receptors or targets influence how effectively a drug binds or acts on its target. Impact. Drug target gene variants affect sensitivity to medication. PCORC1 variants, which codes for protein involved in the vitamin K cycle, impact warfarin sensitivity. Patients with VQ or C1 polymorphism may require lower warfarin doses to prevent bleeding. Beta-1 adrenergic receptor variants in the DRB1 gene, which encodes the beta-1 adrenergic receptor, influence response to beta blockers. Second, LDRB1 polymorphism may make beta blockers more effective in reducing heart rate and blood pressure at low to low doses. Clinical implication of genetic variation including personalized dosage, genetic tested at low for more accurate doses but identify patients with variations that affect drug metabolism. For instance, knowing a patient is poor metabolizer of cytochrome P2C19 helps get lower alternative doses for drug metabolized by this enzyme such as proton pump inhibitors and clopidogrel, reducing adverse drug reaction. By identifying genetic risk, pharmacogenomic testing can help avoid several adverse reactions. For example, screening HLA-B 1502 in Asian population before prescribing carbazepine can prevent life-threatening Stevens-Johnson syndrome. Selecting effective medication, understanding genetic variation, drug targets, and transporters can improve drug selection, choosing medication most likely to be effective for given patient. For example, patients with certain CLC1B1 variants may be prescribed statin less prone to cause myopathy. Optimize the treatment for chronic conditions. Pharmacogenomic insights are particularly valuable in managing chronic conditions like hypertension, diabetes, and depression, where treatment often involves long-term therapy and monitoring. For instance, patients with cytochrome P2 D6 variation may be guided toward antidepressants that are better metabolized by their genotype. Population-specific treatment guidelines. Pharmacogenomic research has revealed that some genetic variations are more common in certain ethnic or geographic populations, allowing for population-specific dosing guidelines. For example, warfarin dosing guidelines consider VK or C1 and cytochrome P2 C9 variants more common in East Asians and Europeans respectively. Challenging consideration pharmacogenomic complexity of genetic influence of drug response. While single gene may influence specific drug responses, multiplied genes and environmental factors interact in complex way. This complexity means that pharmacogenomic is one part of comprehensive approach to personalized medicine. Access to genetic testing and cost. Pharmacogenomic testing can be expensive and not all tests are widely available or covered by insurance. Improving access is key to expand the benefits of pharmacogenomics. Ethical and privacy concerns and pharmacogenomic data become part of medical records. Protecting genetic privacy is crucial. Patients may be concerned about how genetic data could be used or shared outside their healthcare team. Need for healthcare provider education. Pharmacogenomics requires specialized knowledge and ongoing education essential for healthcare providers for interpret genetic tests and incorporate them effectively in clinical practice. Influence of demographic factors of drug response. We will talk about it and we will continue in another part of lectures. This age-related pharmacokinetics. Age can affect drug absorption, distribution, metabolism, and excretion, necessitating different dosage strategies in pediatric and geriatric population. Gender difference in drug metabolism. Biological difference between gender can lead to variation in drug response, requiring consideration of gender-specific dose in a treatment plan, and we will talk very precisely in next lectures about ethnic variability in drug effectiveness. It should be taken into account now, and it is very important knowledge you will find in my next lecture, where ethnic groups may exhibit different responses to medication due to genetic, environmental, and cultural factors, emphasizing the need for tailored therapy. Dear colleagues, because of very deep knowledge, and I prefer that these lectures were concentrated in genetic factors for pharmacogenomic and medicine. We will talk later about demographic factors of drug response and other factors, environmental factors, cultural factors. You will find in other lectures. Today, if you have any question, I think it's new information, and many countries now make now genetic passport. I know for sure that it's already have made Great Britain. You can do it if, for example, it will help you. It's approach for personalized medicine for participants, and I will be very thankful if you subscribe on my YouTube channel. It's a YouTube channel, Drug Safety from Galina Cardera, and my site, All Medicine Net. You can find in my first page of my lecture. Plus, if you have any question, you can send it by email galina.gmail.com. I have received some, and I will make a section with answer on all your questions for this lecture. Thank you very much for your time, for your attention, and I will be thankful if you attend my future lectures, not just in YouTube channel, but in partners. In 21st of November, it will be lecture Pharmacovigilance Guide for QPPV with Bioscience and Nov, and 28 and 29 it will be with Bioscience, it will be with workshop, seminar, webinar plus workshop, and webinar and workshop with standard technology development. It will be pharmacovigilance quality system, and I will be thankful if you will attend it, because we can discuss not just theoretical knowledge but in practical knowledge. Thank you for your attention. I will look forward to you in my lectures. Bye bye.